time it is. Marvin Devine, Huber, Axel, and you know how we do. Yeah, I got the juice. Big game cool, make them look like cool. Always play it cool, that's the biggest rule. Forget what they doing, keep on doing. Like 22. Ask me how I made it right here in the booth. I'm always pursued cause of what I pursue. That's greatness, yeah, I gotta make it, I got things to lose. Boy, just wanna get in my crew, but you can't get in my crew. Me, XL, and Huber, way too fireable. When this joint drop, better call the troops. And when you hear the drop, better raise the roof. Better raise the roof. You already know what happens when we link up. Let's go. Yeah.
Good evening, good afternoon, and welcome to another episode of Kidney Hub East Africa. Now, today, we were supposed to have a guest that came up MIA. We can't get in contact with the guest, so we had to shift our broadcast topic. So we won't be talking to Lori Kennedy today, okay? We're going to be talking about the importance of monitoring during the dialysis process. And I want to say, welcome, hey, Living Life, thank you so much for the Father's Day wishes, and happy Father's Day to all the fathers who may be watching. PT, welcome. Thank you for stopping in. I appreciate your support. So we apologize for not able to talk about, had a guest on. So with that being said, let me bring on our co-host, as always, Brother Moses Kennedy, AKA the Kidney Ambassador, and renal nurse specialist, Tabitha Matekwa. Hey, Brother Moses, Tabitha, how you doing today?
I'm fine, thank you. Yeah.
Tabitha, before we get started, I just want to share something with you. I have some serious concerns for Brother Moses. He doesn't look well to me, even though he said he's okay. I just something in my gut saying that he's not okay. And I don't know, I may be overreacting, but just something in my gut tells me something's not right.
Last week he was not well. I called him and he was on treatment. I don't know by now whether he has improved. The way he was last week, he was bad. He was not well last week.
Brother Moses, you talking about? Are you speaking of Brother Moses wasn't well?
Yeah, Brother Moses
Yes, we
wasn't
can hear
well.
you.
Yeah.
Brother Moses, please, how are you feeling right now?
Moses.
Can you hear me, or is there a delay?
Me can hear you. I don't know about Brother Moses. Can you hear Steve?
Yes, I can hear you.
See how he's responding, Tabitha? That just something doesn't
I
seem right. And if you could check on him once the
I
broadcast.
can hear you.
I mean, Brother Moses, are you okay? Please.
Yeah, I'm okay.
Okay.
I'm okay.
I want to take your word for it, but I want to be honest with you. I don't believe it.
Yeah. He doesn't look well.
Yeah, I mean, Tabitha, you're a renal nurse specialist, and you're there in Kenya. From your assessment of what I just was speaking to him, he's coming back on, did he seem well to you, or like something may be going on?
Most likely, maybe he has not recovered fully, because last week he was saying he's not well. And he had told me he was not feeling good. He's not feeling well.
Yeah, we lost him again. Yeah, I really have serious concerns about that. And that brings us into the topic that I want to discuss with you that I'm sure you're all too familiar with. And that's monitoring the dialysis process.
Yeah.
You know, a lot of individuals, whether it's East Africa, United States, United Kingdom, Asian Pacific, wherever, dialysis is dialysis. And when you're talking about monitoring the patient while they're on their treatment, that's very important, because hemodialysis requires keen observation on the part of the nurse or the technician. And now complications can arise instantaneously. A lot of people don't know that. Blood pressure and pulse checks here in the United States are taken and recorded every 30 minutes. Some places they may do every hour or more frequently as necessary. And during that time when we check in the vital signs, machine settings are adjusted frequently during the treatment and recorded on the treatment sheet. Excuse me. Now, can you talk about the importance, even where you're at, of monitoring the patients during the hemodialysis process?
Thank you. Thank you, Brother Steve. It's very, very important to monitor our patients when they first come into the dialysis. you can check on them. Are they okay as they are coming in? Are they able even to stand on the weighing machine? Are they, how are they? Do they have shortness of breath? When you look at them, do they look edematous? When you look at the eyelids, are they swollen? At how they are breathing. Are they having shortness of breath? When you look at the legs, is there edema? So it's very important to see how they come in, and even as you are interacting with them, you are checking on how they are. So you can do head to toe examination. You can also listen to the chest using the stethoscope. At the same time as you are checking on them, see if they, you use your stethoscope to even listen to the chest, which is very, very important. Again, as you're looking at them, look at are they having any pallor? You can check on their eyelids. You can check on their tongue. You can also check on how as you touch the fingers, how is the refill? It can really tell you a lot. And then you can also check if they have any results. How is the previous HB, the hemoglobin level? Because if the HB is low, especially when it's lower than 7, the patient might require to be transfused. Then you also need to interact with them and ask them how they were, how they have spent the last 2 or 3 days. Again, also, how is their urine output? And you can also compare with how they are also taking in. How is their feeding habit the last 2 weeks or 2 days? Were they able to eat? Because again, if they were not able to eat, or let's say, like, for example, maybe they were vomiting, you can also start suspecting they are having a problem. You might need even to withdraw blood, do a full blood count, to check on how they are doing. So it's very, very important to see how your patient has come in. And as your patient comes in and maybe you want to dress the catheter, you open and see, is there any sign of infection on that catheter? Again, also, if it is the fistula or the graft, how is it? Is it something that you can also work with? And from there, now you can clean the patient, prepare to connect the patient to the machine.
So let me go back to, I know in Kenya, they probably have a consent form. When patients start dialysis, they have to sign. They have that here in the US. So here, where I feel, in my opinion, that a lot, not all, but many patients miss on the consent form is a part. So here, let me just read a section of the consent form, and then I want to come back and address it. So it says, I have been informed that the following risks are associated with hemodialysis, and that while such risks are not common, one or more can occur and be potentially life-threatening. 1, bacterial and or viral, talking about hepatitis B or C, contamination of my blood, which may cause infection or bacterial infection of the blood called sepsis. 2, bleeding due to blood clotting problems or disconnection of blood tubing. 3, destruction or the breakdown of red blood cells known as hemolysis. 4, internal bleeding or bleeding from the access site. 5, infections of my access site, catheter or fistula infection. 6, introduction of air into my bloodstream. 7, shock or cardiac arrest. 8, allergic and toxic reactions to drugs, solutions, artificial kidneys, or other equipment used during the hemodialysis treatment. And last, clotting of my access or infiltration of my access. Then it goes on to say, I have been informed that there may be some side effects associated with hemodialysis related to fluid and chemical changes during or after the hemodialysis treatment. Some of the side effects are osteoporosis, electrolyte imbalance, headache, nausea, dizziness, fainting, irregular heartbeat, decrease in blood pressure, muscle cramping, and mild confusion. Now, with that being said, do many patients, like where you work at your hospital or you seen, are they educated about those side effects that can occur during treatment, or they are hit like by surprise, and when this happens, they didn't know that it could happen?
Mostly when they're starting dialysis, they may not be aware of all these, but with time we also do health education to them. Even as the nurse is taking care of them, is also supposed to be doing part of the health education so that they can understand nausea and vomiting can happen. They can get osteoporosis, muscle cramps can come in, and even the blood pressure can even go down. They can get hypertension. So mostly when they are starting, they are not, most of them are not aware of all this. But with time, we continue educating them and sensitizing them on all these side effects. Yeah.
So that's one of the reasons why I try to do this show and another show called Dialysis and Life with Steve the Kidney Nurse, or just even lives to talk about information like this. Because what happens, I know here in the US, and I've seen it all too many times, when we admit a patient, there's like a stack of papers about that thick, right? And it's called the admission package. And there's a lot of papers that patient has to sign: consent form for dialysis, patient's rights, responsibilities, HIPAA, assignment of benefits, and a lot of other stuff. And many times when people start, they may be feeling bad and just want to get on treatment and rush through the paperwork and just sign it, and may not be able to get back to read it or go over, and it may slip through the cracks. And so when something such as, let's say, person has a headache after dialysis and it lasts all day and they didn't know, but here in the consent form it says, I have also been informed that there may be some side effects associated with hemodialysis related to fluid and chemical changes during or after the hemodialysis treatment, and headache is one of them. But if the person is never educated that that could happen, then they may think it's from something else. I don't know. What is your thoughts on that? And the importance of educating the patient, not like you said as they go on, but when it comes time when they start treatment. Is the process the same way in Kenya? When someone starts, they fill out the paperwork and then they put them on the machine?
Okay, when they are starting dialysis, we have a consent for catheter insertion, and before catheter insertion, we cancel them. Those who can understand, because sometimes they are too sick to maybe comprehend what you are saying. They sign the consent, or the nearest relative is the one who is explained and signed on behalf of the patient. But as soon as the patient is able to understand, we talk to them, we counsel them, and we explain to them all the logistics about the dialysis, the need for even adherence to the medication and even to the dialysis. We also take time to even educate them much more on the dialysis journey. Yeah.
So let's talk about some of the medical complications that can happen during dialysis. And I'm sure you've seen many of these complications: hypotension, muscle spasm or cramping, nausea and vomiting, chest pain, pruritus or itching, shortness of breath, and access insufficiency. How is low blood pressure treated if a person dialysis there?
Okay, if the blood pressure drops, we place the patient in, we call it Trendelenburg position. Yes, but for the sake of someone who does not understand the medical terms, we lift the legs a little bit up so that the head is lower, and we also infuse just a little bit of saline, like 200 mils, just to see if the blood pressure will come up. At the same time, you can also check on the how much fluid were you removing. You may need to just go slightly lower, because maybe we have removed a lot of fluid from the patient, so that again, at the same time, we don't want to leave the patient with a lot of fluid. And again, you can still do a quick physical examination on the patient. You also need to do the blood pressure again to see, after you have infused and you have also lifted the patient, you've put the patient in that Trendelenburg position, you need to recheck the blood pressure. Is it coming up? If the blood flow rate was high, you need to lower it. If it, let's say like it was 300 or 350, you can come to around, maybe around 280 or even 250, as you're also checking on the patient. Yeah.
When it comes to cramping, do you see patients in Kenya using certain remedies to stop the cramping during treatment? Like here, they have some people who may drink pickle juice during treatment to help with the cramping. But there's nothing medically established that says, pickle juice release cramping, but some people do use it and they say it helps. But is there any remedy like that some patients may use for cramping? Or, I know in the clinic, if somebody starts to cramp, you're going to stop pulling fluid and give normal saline.
Yes. I haven't seen any remedy being used, but mostly we infuse some saline to see if the patient is going to respond well. Just like 200 mils, it makes a lot of difference. Yeah.
Oh, yeah. Fluid wise?
A flow, you reduce the blood flow rate, because if it is very high, it can also cause the cramps to be there. Yeah.
Mm-hmm.
Yeah.
What about nausea? Do you see a lot of people deal with nausea while they're on the machine?
Yeah, we have several who also deal with nausea, and if the blood flow again is high, you can you reduce the blood flow rate first, and then you observe. If the patient had really vomited, you can still infuse some little saline because of the volume that has been lost. Yeah. And we also check on the blood pressure, because sometimes it could also be high, or it still could also be low.
Mm-hmm.
Yeah.
Tabitha, let me ask you, how far do you live from Brother Moses?
Moses lives in Kisumu. It's like around 400 kilometers away.
400 kilometers.
Yes, yes.
What is that in miles?
1 kilometer is how many miles,
Take
Roy?
about 2 hours to get there, something like that?
No, for around 5 to 6 hours to be there.
Oh, that's a long way. If it takes 5 or 6 hours.
Yes.
Yeah, I'm concerned because he came back on and then he dropped out.
Yes.
And now he didn't come back.
Yes.
So I'm just that's 248 miles.
Yeah.
Oh, okay. Is that 5 hours by train or something like that?
By bus or by personal car, 5 to 6 hours.
Wow. Because 248 miles is like about 4 hours.
Yeah.
Yeah.
Considering the traffic jam sometime.
Oh, okay. Got you.
Yeah.
Tabitha, let me ask you, do you see a lot? This is one problem, complications that I didn't mention in that list that happens, and that's blood loss.
Blood loss?
Yeah, whether it's from a clotted dialyzer or a needle coming out the access or lines disconnecting. Do you see many of those type of incidents happen, or have you ever had to deal with a situation like that?
Yes, many times. Sometimes a patient can be, let's say, for example, maybe a patient is being inserted a catheter, and for one reason or the other, the doctor can puncture, and there's bleeding, which can happen, leading to blood loss. When a patient is on dialysis, there could be a problem with the access. Therefore, the machine will keep stopping and will keep stopping, and then again, the patient there could be a clotting, and therefore you might need even to discontinue the patient from dialysis, and or even maybe even discard part of the blood that is in the bloodline, or even in the dialyzer, because the clotting was so severe, and again it was so bad. Sometimes there are patients you need to dialyze without heparin, and maybe you needed to do either the salines or something like that, and some of them it becomes sometimes, and if the access is bad and you are dialyzing without heparin, it can be chaotic. Patient can so easily clot. So it's something that is it's a common phenomenon. It happens. for patients who are on dialysis, and patients can lose. At the same time, we say that a patient who is on dialysis, let's say, for example, the one who is using a catheter, we remove just a little blood as we are connecting the patient. That is part of the blood loss again. And whenever there is, let's say, for example, whenever a patient is having infection also interfere with the way the patient is, and they are likely to anemic because of the infection. Yeah.
Okay.
So there's a lot.
Yeah, let me just share some of the causes of blood loss during hemodialysis that many people, whether you're in East Africa or United States, may not know about or understand. One, arterial venous bloodline disconnection. And let me show you how that can happen. So this is an arterial bloodline right here. Wait a minute. Let me see if I can. Hold on. Let me see.
Yeah.
No, hold on. All right. Well, anyway, this is an arterial bloodline, and you can tell because of the red on it. And so,
yeah, it's a red one.
About line disconnection, you have to see, and if you watch it here, right, it's a male part, and then they consider this the female. So it's like a lure lock. It fits in and it twists. But if people are rushing and they connect it and don't really twist it tight, I mean, it can come apart.
Yeah.
Especially if they rushing. You see, chat? Right here. So people got to be careful when they rushing or hooking up. But this is the line separation where it can happen. And not just the arterial, but even the venous line, which is the return line going back to the patient. And we've seen that happen many times when it comes to, person having the catheter and it's not tight and it comes loose. And instead of the blood going back into the patient, it's spilling out onto the floor. This happened many times here in the States. Another reason or cause that can happen with blood loss is the needle. The needle out of the access is not taped down right. Patient make a sudden move or moving their arm, and if it's not taped down, it can get snagged on something and pull out. What we call dislodge. Also, the filter could leak and cause all the blood leak because of the fibers. And the blood can clot in the filter, and you may have to throw the whole system away, the lines, the filter, everything with blood still in it because we can't return clotted blood back to the patient.
Yeah.
What are your thoughts on that, Tabitha? What I mentioned, how one can lose blood during hemodialysis.
It is very true. If it is not, if you don't tie it tightly, the blood can start, the pressure will cause the blood to start leaking on the lines, either arterial or even the venous. That is very, very true. At the same time, the needle, if just the way you put it, that if the patient moves a little bit, it can, the needle can dislodge, and the patient can lose blood from the fistula, or maybe let's say from the graft. And if the needle comes out, that blood comes with a lot of pressure, and we usually say it's like a waterfall from, especially from a fistula or even from a graft. Therefore, it's good to be very, very careful and to make sure we have secured very tightly. And even as we are doing education on our patient, we need to tell them, especially if it is a fistula, to be very, very careful. If a patient also has a temporary catheter, sometimes the stitch comes out. And when the stitch comes out, if the patient moves a little bit, the catheter can even dislodge as the patient is on dialysis. Therefore, it's good for the nurse also to make sure it's well secured so that our patient doesn't lose the blood. And again, also we educate the patient on the need to position well, because we don't want that patient to lose blood. Yeah, thank you.
Okay.
Yeah.
Now let's talk about the treatment for and the intervention for blood loss. So for people who may be watching, and if this happens, at least you'll know, because some staff may not, if they knew, they may not know how to address it or intervene. So one,
So,
can you hear me?
okay. I was saying it's good for as someone is listening to know that part of the function of the kidney is to help with maturation of the red blood cell, where it produces what we call erythropoietin. And now, because the kidney is not working properly, there is that inability of the blood to be well, how do I put it? For that blood to be, we need to really take care of that blood so that the patient doesn't lose blood, because the kidney already has an issue, and it's like we are trying to help the patient to stay with a normal HB if we can. But it's good for you to understand that about the maturation of the red blood cells. Yeah.
Right. That's understandable. Definitely, if I don't know how it works in East Africa, but here something like this happened, they're able to draw hemoglobin to check the blood count. Now I don't know if that's able to happen, if the clinic would get reimbursed, or how that works in Kenya when it comes to checking hemoglobins, and how often, and if they get reimbursed. Here, patient has an issue with their hemoglobin. They do pretty much hemoglobins bi-weekly instead of weekly.
Okay, for our patients, the cover that we have for the national hospital, the insurance for the patient, it pays only once per month for the UEC, and also for the full blood count. So in case there is a problem in between, the patient has to dig deeper into their pocket, and there is no reimbursement, but only once a month. Yeah.
Wow. So normally what normally happens with blood loss, the treatment here in most dialysis facilities, if it's a large amount of blood loss, They're going to monitor the vital signs. They're going to support the blood pressure as needed. Apply pressure to access as indicated for dislodged needles. Notify the physician, nephrologist, obtain labs as ordered. They may order a CBC to check your hemoglobin. Return the blood if possible. If you got a blood leak, we're going to test the fluid or the dialysate for the presence of blood. If it's blood can come through that membrane, if that membrane fails. So we had these strips that we test for blood leak. And if it is a blood leak, we're not supposed to return your blood. Now, if you got clotted lines, blood leak or clotted lines, you want to restart the patient with new blood lines and or dialyzer. The patient is stable. And we document the incident, interventions, and the patient's response. But let me ask you this, Tabitha. If a patient clots on the machine, or if the filter clots, and say they halfway through the treatment, or not even halfway, do y'all set up a new filter, or that's it because they only reimburse for one treatment? I mean, not one treatment, but for a certain amount of consumables.
Okay, if the patient's clot, you just need to document and also write a note to the one who supplies from the store, so that you are given the dialyzer and the bloodline, but with a statement that the patient clotted, so that you get a set of others and the patient doesn't have to pay for the lines that he has received. Yeah.
Did you say the store?
Okay. What happens, like in our department, we have someone who is managing the store, but it's just within the our unit. So we just write a note to the person managing the store where we keep the dialyzer and the bloodline. And then yeah, we also document that the patient clotted. Yeah.
Oh, and you can go down there and get one and set it back up and resume the treatment.
Yes.
Wow.
So that the patient doesn't go home without being treated.
Wow. Does that happen the same day, or they have to come back?
Just immediately. It happens immediately because the patient has to finish the treatment. And again, you also assess if the HB is very low and you needed maybe to dialyze with blood. You can take the sample and see how fast the patient maybe can get blood. Then the patient can be transfused if it was severe.
Wow. Wow. Okay. Well, I ain't gonna hold you. We're gonna cut the show short today by 15 minutes. Because Brother Moses is on my mind. He hasn't came. He normally comes back, and he did come back, and then he, went off screen. Or not, he wasn't on screen, but out of the lobby area. So that's kind of concerning me, and I just hope he's okay.
Yeah, I followed through.
I know
he had told me that he's going to come to Nairobi this week, so maybe he will travel. But I'll do a follow up on him to see how he's doing.
Yes, please do. Because just something my gut felt like something was wrong. So, well, all right, Tabitha. Well, thank you for coming on. I'm not sure what happened to our guest.
Yeah.
you know, it happens like that. But thank you for coming, taking the time to come on and discuss some of the complications that occur during the hemodialysis process and why it's important for people that work in this field to monitor that process and monitor their patients. Now, one more question before we go. When y'all do your vital signs, is it every half an hour or every hour where you record the blood pressure?
We usually record every hour. Yeah, and we also have a dialysis chat where we record.
Yeah, we do it every half an hour. Check blood pressure.
And then after the patient has also finished dialysis, we also do the vitals. We also check on the weight and compare also with the weight that he had he was entering there, which is very important.
Absolutely. All right, Tabitha. Well, we'll see you next week. And again, thank you. Have a great week. And please let me know if you hear anything on Brother Moses.
Yes, I will. Thank you. I'll talk to him. I'll give you a feedback. Thank you.
Thank you so much. All right, Tabitha.
Have
I'll
a
see
good
you soon. You too. Bye-bye. So everyone, thank you so much for watching. Living Life, thank you. Yeah, I'm definitely concerned. He just didn't seem right. Something just seemed off. So with that being said, we see y'all later tonight with Dialysis in Life with Steve, the kidney nurse, as I talk with Woodrow Woody Mitchell, DJ Woody Wood. That's 8 o'clock tonight. He's from out Harrisburg, PA. I know, Living Life. And that's going to be a great show. He's been on dialysis 16 years. Now we have my co-host, Kanisha Williams, with me from Jamaica, who works in dialysis as a dialysis technician. So we're going to be talking to Brother Woody tonight at 8 o'clock. Hopefully we don't have no hiccups. But thank you, everyone, for coming. We see you soon. God bless. And stay blessed and encouraged. It's your boy, Steve, the kidney nurse. I'm out. Peace.
Yeah, we on Steve on the mic. Yeah, the nurse got skill. Break it down smooth. Keep the whole squad chill. Talking about kidneys. Yeah, we keep them on track. If your numbers off balance, he gon' bring them right back. Got the wisdom on deck. No stress, just facts. Hydration, motivation every time he reacts. From the clinic hallway to your podcast feed. Dropping gems so fresh. Yeah, that's all you need. Steve, the kidney nurse. Yeah, you know the name. Keep your body in check. Yeah, we play no games. Real talk, real